Excuse me. Well, good morning. Thank you for the kind invitation and introduction. I hope that this overview of the management and of mucogingival conditions, previously known as gingival recession, will be helpful. There's a lot of information, but my desire this morning is simply to work you through it, and you're more than welcome to have the presentation afterwards. Can you do the next slide, please? So the aims really are to provide you all today with an update of the causes of gingival recession with or without dentine hypersensitivity. Historically, this presentation is based on a previous book chapter that I submitted for publication. It now has a second edition, and really it was for undergraduates and general practitioners. So that's the basis of the presentation, and I've updated it from the book chapter. So I hope it will be helpful for you. Since, however, writing the book chapter, we now have the new classification and management of gingival recession following the World Workshop in 2017. The proceedings were published later, I think, in 2018. So I'm adding that as well to the presentation. I think, to be fair to everyone, and including myself, that there's not a lot of research coming out, is gradually coming out on epidemiology based on the new classification. So a lot of the information is still very much based on previous classifications, but I've tried to address that slightly in the presentation. Hopefully I give you some guidance to all the clinical outcomes arising for gingival recession. We'll discuss the importance of the various factors, the importance of gingival biotype, which can affect the outcomes in root coverage procedures. And hopefully there will be some practical tips on how to manage the condition and associated conditions using both non-surgical and surgical approaches. When we look at this in terms of management, we have to avoid being dogmatic on how we treat patients. Each patient is individual, and so in many ways we can't have a formula that fits everyone's purpose. And I think this is important to accept. I'm always reluctant to say this is the only way to do something, because you as clinicians have the patients in front of you, and you know their needs, often with their cosmetic or assessment needs may compromise what you actually want to do, and that's for you to decide what you want to do, whether it's a non-surgical or surgical approach. Next slide, please. So a brief introduction. Cortellini Posada in 2018, this is based on the workshop, defined recession, gingival recession as an apical shift of the gingival margin with respect to the cemento-enamel junction with associated attachment loss or CAL and exposure of the root surface to the oral environment. I think this is an interesting definition because it combines what we often see historically as buccal or facial gingival loss, clinical attachment loss, with probably what we call interdental loss. So I'll explain that. And there are recognized several outcomes: aesthetics, pain, often dentine hypersensitivity, or if you're from the periodontal world, root sensitivity, and periodontal concerns such as plaque retention, inflammation, and also root caries, and this phenomenon, which is also recorded in the literature, the so-called non-caries cervical lesions, NCCLs. Yes. Often historically we might have seen that as wedge-shaped lesions as well. And when you look at the literature, you actually find that people record this in separate ways, but I think we need to actually step back and try and assess it as one. Next slide, please. Next slide, please. Okay. This is a table, again, historically, combining several papers, and I probably need to update this again, but these are the findings from several papers from Kassab and Cohen 2003, Kamal 2005, Orchardson and myself 2006, and there are others, and I've got this in the presentation. What they found was 88% of individuals tested were over 65 years of age and older. There were also 50% of the individuals 18 to 64, 79 individuals examined. Of those examined, 24% had dentine hypersensitivity associated with gingival recession. And from the overview by Orchardson and Gillam, we found that 69 to 74% of individuals had dentine hypersensitivity, although when you clinically evaluate these individuals, it generally goes down to about 15%. Next slide, please. And this is from the study from Cohen, and again, it really outlines what I've just said. There has been a higher prevalence figure reported for females. This may not be statistically significant. It may be numerically significant, and this may be due to a greater awareness and interest in general and oral health issues compared to males. Although one's got to be careful when we say this, but probably that females are more likely to go and see dentists and doctors about health issues. Males tend to be reluctant to go, and they often report late. And if we take ourselves out of the dental field, this has a major issue with other forms of cancer. They're reluctant to do it. And the question you should ask yourself is that who in your household makes the medical and dental appointments? Certainly from my experience in the United Kingdom, we often find it's the female partner who makes the appointments. But again, it's a numerical figure, not necessarily a significant figure. Next slide, please. And it's clear from these various studies historically. I put the terms GR and DH, but gingival recession, dentine hypersensitivity. And you can break it up into at least two groups. The populations of patients with high standards of oral hygiene, where the condition affects mainly the buccal surfaces of the, or facial surfaces of the canines, premolars and molars. And also populations and patients with poor plaque control who have been deprived of professional dental care and education, where recession defects may be more widely distributed around all four surfaces of the affected teeth, often in the interdental areas. So there are clearly differences. And also with those with periodontal disease, the effects of periodontal treatment may also have an impact on this. Next slide, please. This is an interesting study because it bridges the gap of, at that time, 2013. So the research was done earlier, but it was published in 2013. And there was an evident gap in our understanding of young adults. So this is a study, a questionnaire, clinical study of European adults, 18 to 35, over 3,000. And the results were interesting. What they found that when they did the questionnaire, 27% of participants reported that they had sensitivity in daily life. But when some of the individuals were examined, they actually responded, some 42%, to sense stimulation. And this is often a reverse of what we see, as you might have recalled from my remarks earlier. What the figures show that generally questionnaire studies have higher prevalence rates than clinical studies. But here we actually find that the reverse is true. And what you often find from a clinical perspective, that patients may actually not complain of sensitivity, or more likely, if they have sensitivity, as the study showed and other studies have showed, that there is coping mechanisms that they are able to manage the discomfort without going to the dentist. And certainly from other surveys, we find that most people don't bother seeing the dentist, and most patients don't actually seek treatment. And again, you've got to be careful, because this depends where the studies are reported. But here they did find a relationship between healthy erosive diets, tooth wear was very key, so dentine hypersensitivity and recession. So there is a strong relationship. Now, as we get older, we probably get more facial or buccal recession. It's interesting when you look at the epidemiological figures from the Americans studies. You may often find that after a certain period of 50s, over 50s, 60s, that pocket depth values plateau, whereas gingival recession scores increase. So the question then you should ask is, are we simply looking or recording at a aging process on top of perhaps a periodontal issue? Next slide, please. Again, this is very dated, but Baker and Seymour, 1977, proposed a hypothesis which would explain gingival recession. And really, it's what I've just been outlining. It's either good oral hygiene practice, what we call overzealous toothbrushing, or the effects of periodontal disease. So basically, you can have damage either done internally, inflammatory change due to periodontal disease, or external pressures. Either way, you end up with recession. However, I think the key issue here is a relationship with the gingival biotype and the quality of underlying bone. And as most of you know, that generally when you get gingival recession, there is very little buccal or facial plate underneath the gingiva. And a basic or a fundamental rule is that if there's no bone, you will not get the gingival tissue staying there very long once it's subjected to any internal or external trauma. The reason I say this is that we need to remind ourselves that when we do any gingival procedures, surgical procedures, we still may get recession after a period of time. And if there's no bone replacement, the same thing will happen, i.e. gingival recession. And even in the best hands, with the Cortellini group, they recognize after, I think, 10-year reviews that they do get some recession in some sites. Next slide, please. Next slide. Okay. Briefly, although this is not primarily a talk on sensitivity, the various theories behind it, but basically the current theory is the hydrodynamic theory. It doesn't explain everything, but it's basically based on open tubules and fluid flow. and the pain or stimulation mediated by what we call A delta fibers, what we have to acknowledge in treatment is that simply we either block the tubules through toothpaste or sealants and so on. There is the so-called potassium ion theory, but not everyone is convinced about that. But basically, treatment is through, as I've just mentioned, toothpaste for mild to moderate generalized sensitivity, and in office or professionally applied sealants and such like. And again, with even before the concept of minimal invasive dentistry, there was always a non-invasive philosophy with this, with the treatment dentine hypersensitivity, and it only progressed to a more invasive treatment philosophy if the problem wasn't resolved. Next slide, please. Next slide, please. Thank you. So here we have three presentations. As you look at the screen, they look similar, but they're caused by different phenomena. The first slide is caused by the clinician. This is a result of surgery following successful oral hygiene therapy, non-surgical, and subsequent surgical treatment. A simple open, in this case, open flap surgery, I think we did, and you can see this patient is left with gingival recession. It's posterior. Obviously, we have the anterior teeth here, but you can see there's recession on the premolars and molar. In most cases, that would be acceptable unless you've got a really wide smile. The middle slide is gingival recession associated with overzealous brushing techniques. It used to be called traumatic toothbrushing. The reality from studies show that it's not the toothbrush that's causing the problem, but the abrasives in the toothpaste, again with excessive pressures. This has been mediated to some extent with the advent of pressure controlled powered brushes, which try to minimize. But you can see here the gingiva is very healthy, but you can see the quite clearly the effects of overzealous brushing. Again, it exposes the dentine surface. The question is, will they get sensitivity? It may well be with the so-called burnishing effect that in this case they may not get sensitivity. The good thing as well, as you get older, there's a lot of sclerosis and secondary tertiary dentine laid down, so the bulk of the tooth is more dentine, and although people over 50, 55 still get sensitivity, it's less likely to experience it than our younger patients. On the last slide, this is gingival recession. They just moved, don't worry. On the last slide, before they turned to keep it on this slide, it's okay, was simply caused by periodontal disease. Right. So if we go to the etiology, there are multiple factors. The key thing is that, and we'll see this on another slide, but the basic scenario is that you need the gingival tissues to be lost before you get exposure of the dentine surface. Once that occurs, there are two biological processes what we call lesion localization and lesionicity. So once it's exposed, then the acidic or erosive components within the healthy diets often will open up the tubules, and acid erosion appears to be the key issue here. I would suggest that looking at the various publications, we should really look at the role of gingival recession in dentin hypersensitivity as a predisposing factor rather than the primary cause. Next slide, please. So here is this diagram, which is taken, it's a combination. Marilena was a postgraduate student, and she combined this from Marina et al. 2010 and Kassab. And you can see that there's a number of factors that are involved: mechanical forces, the anatomy, aging, pathological factors, and iatrogenic factors. Orthodontic movement can impact. Sometimes simply putting rubber dam clamps, matrix bands aggressively can cause temporary issues. Faulty toothbrushing by the patient, which needs to be corrected. And as you know now, that people are using oral piercings more, and on the tongue, the lips, and even on the gingiva. So again, they could impact on that. And from the anatomical framework, which we're kind of born with, we would have bone dehiscences, our malocclusion, tooth position, our gingival biotype. We might have aberrant freedom attachments. And what is always an issue, I think, is this concept of quality of the attached gingiva. And you may see on the slide little asterisk and a star and a cross, and that's to distinguish between predisposing and precipitating factors in the condition. And again, with the pathological factors, that is plaque induced inflammatory change. Next slide, please. Thank you. So we look at classifications now, and historically, Miller classification in 1985 was the one which was considered to be a benefit and an improvement on previous classifications. One was Sullivan and Atkins, I believe. And the advantage at this time was it was able to correlate the treatment progress outcomes and the anatomical features. Next slide, please, with the prognosis. So here we have, if you look down from the original Miller 1985, a classification going from top to bottom, class 1, 2, 3, and 4, and you can look at you can see the cartoons, if you like, the various levels of progression of loss, going eventually beyond the mucogingival junction. And the key thing with class 4 is the fact there's severe bone and soft tissue loss in the interdental, which is historically a considerable problem. So if we're looking at treatment and coverage of the root surface, in class 1, you get 100% success, as with class 2. The success goes down to 50 to 70%, only partial. And the problem then is the height of the contour, the interproximal tissue, how to replace that. And obviously with class 4, it's much more difficult, and it's unpredictable and requires adjunctive treatment, i.e. using orthodontics. This is historical. The idea with orthodontics then is to bring the teeth back into the bony envelope, and then you may get more gingival tissue. Next slide, please. Now, since the Miller classification, we now have the 2017 workshop, and you can see now that it's now classified as mucogingival deformities and conditions. And this is a slide, and I acknowledge Phil, our colleague of mine. And so the dynamics have changed. Now, to be fair to Miller, Miller recently wrote a review where he recognized the limitations of his classification. And as we'll see in the next slide, can we have the next slide, please? And Cortellini Posada with this update for 2018 suggested that there's an updated recession classification, and it was really based on the interdental cowl measurements proposed in 2011 by Caro et al. It's interesting that it's been proposed for a while, but it wasn't, apart from some researchers, it wasn't implemented in general use. When I say general use, I'm really talking about specialized perio treatment. And the argument was that the new classification overcame some of the limitations of the Miller classification. The difficult interpretation with class 1, 2, and 3, and the use of bone and soft tissue loss as an incidental reference to diagnosis. And we have this issue of the periodontal destruction, which is very difficult to treat in the incidental outing. And to be fair, as I was highlighting, with Miller's classification, he really proposes when the root coverage techniques were at their dawn, very in their infancy, and unfortunately his techniques and forecasts of potential root coverage is no longer matching the treatment outcomes of the most advanced surgical technique. So I think we should still recognize the value of the Miller classification. It served us well, but it didn't take into account the tremendous strides that have been made with surgical techniques and also materials that are available. Next slide, please. So this is the now divided in 3 recession types, type 1, type 2, and type 3. And again, it relates to, it's interesting. If we go to the next slide, I think it may be easier to explain. And you can see in diagrammatic form, which I took from Jepson, I think. If you look at here, and it's really the difference between, if you look at what's called RT1, recession with no loss of interproximal cowl, interproximal CEJ is not visible. So you see the probe there. It's when you RT and R3, you see the difference where there's a loss of the interdental proximal cowl is less than or equal then to the buccal or facial cowl loss. You can see so it's diagrammatically shown here. So here's the measurement from the visible CEJ down to the amount of loss down to the mucogingival junction, and here we see the, if you like, the interproximal or interdental, and it's less than or equal to the buccal cowl loss. So they're making that distinction, and in RT3 you can see the reverse is true. So you're seeing more interproximal loss of cowl is greater than the loss of the buccal. So I think that's these cartoons show it better than just reading it off the screen. So that's the difference. One, there's no change, if you like, no loss in RT1, but the RT2 and RT3 is where there's that subtle difference. Now, we'll go on to the next slide. Next slide, please. So the Caro, according to Cortellini and Posada, or Bisseta, sorry, is a treatment-oriented classification, and it forecasts potential for root coverage through the assessment of the interdental cowl. And again, this concept of if we then compare the Caro RT1, it covers the old Miller class 1 and 2, 100% coverage can be predicted. In Caro RT2, overlapping the Miller classification 3, indicates there's the limit of the incidental cal loss within which 100% of root coverage is predictable, however, applying different root coverage procedures. And in the Caro RT3, overlapping the Miller class 4, full coverage is not achievable. So really, the situation with the Miller class 4 has still not been resolved, even with the RT3. So I think from a clinical point of view, we have to manage it slightly differently. Okay, next slide, please. Now, I did find one recent study this year where they looked at implementing the new classification system, the RT1, RT2, and RT3 in Italy, in Turin, with about 736 adults. And there they were able to distinguish between the various prevalence based on the RT1, the classification. So you can see with this abstract, and what they found was RT1 and RT3 are fairly common findings in the Italian population and are significantly associated to different contributing factors and tooth type distribution. So I think at the moment it's still, classification is still in its infancy. I think there still may be problems to iron out, and not only how we assess it, but how then we subsequently go on and manage and treat it. Next slide, please. Now, here's reproduced from the new classification, and it's a guide to how you record this, and obviously then it helps you make your diagnosis and management. So it looks at obviously no recession, RT1, RT2, R3. It looks at the recession depth, the gingival thickness type, the width of keratinized gingiva, the CEJ, cement enamel junction, and the step, whether the presence and absence of and if you can see the key there, I think it's if you look at the CEJ, they've looked at it detectable CEJ and undetectable CEJ, and then they've looked at this concept of a cervical step, the presence or absence. I think this is quite interesting because from my personal clinical experience over the years, one of the difficulties I've had, it's very easy often to pick up the CEJ for measurements facially or buccally. It often becomes harder to follow around incidentally, but also I found, I don't know what you found, on the lingual side, often it's indistinguishable, and it's often very difficult to detect. And how are there any tips? Well, often we know that the CEJ, particularly incidentally, goes, if you like, in a almost like a horseshoe, so you can try and follow it that way. Running the probe to detect any steps or any change often is difficult. Which way is best? Do you go down with your measurement when you use your probe, very tactile, to try and find it, or do you go up? And that's something which I'm sure we all have an opinion of, but it's interesting, and it'd be interesting to see how this will actually work out in practice. My concern at the moment, and it's only a concern with this new classification, obviously it's predominantly aimed at periodontal specialists, but certainly in the United Kingdom and some, I think, other European countries, we used to have the basic periodontal evaluation or BPE or equivalent. And that now is being, if you like, in part of the new classification, being incorporated into that, and therefore general practitioners have to be aware of it. Now, the time constraints within our state National Health Service, it's going to be very difficult for practitioners to spend a lot of time on this. They will be obliged to do it very briefly, and obviously there's a cutoff where if it's over a certain classification level, then they should refer to a specialist anyway. But I just wonder how, with the time component and the question, and again, this is just formative in my mind at this stage, and it may change over the years, is with the change in classification, will it benefit our management? What percentage of improvement in our management will occur? I've over the years, I think I've had probably about 3 classification changes, and no one seems to be happy with them. There's always a change. So maybe, I don't know, this isn't a prediction, but maybe in 10 years time there'll be another classification. I have to say I won't have to worry about that, but some of you might. Well, let's move quickly on, and I'll go. Let's look at some of the predisposing factors: anatomical recession, tooth position, overcrowding, bulbous root structures, and enamel pearls often can create problems. I think you can see enamel pearl there. Often you can only see that when you go in periodontally surgical. Next slide, please. There's always been this issue about quantity of attached gingiva, and there was a definition years ago which seems to keep coming up about less than 2 millimeters width, of which less than 1 millimeter is attached gingiva, and historically they consider the absence of a certain zone of attached band of gingiva would reduce the tissue and resistance to plaque accumulation and muscle attachment, and subsequently lead to recession and pocket bed. There's an issue. There's no published evidence, however, to suggest that a lack of zone of attached gingiva results in increased incidence of soft tissue recession in patients. Here's the key: maintaining a proper or a good level of plaque control. So really, it's based on the patient's plaque control. So from a clinical perspective, we need to measure things regularly so that we can actually, let's just see the slides going without me thinking. We need to measure it, and the key thing is there any increasing loss in a specific time frame? If we look at the advantages of a thick gingival biotype compared to a thin gingival, it's better to have in reality a thick gingival biotype because there's more underlying bone and it's perhaps more predictable for successful treatment. Thin gingival biotypes are problematic, and next slide, please. So I've just alluded to it's an alveolar bone, which is key, but also the tooth position. And if you move the tooth position, i.e. orthodontically or through processes of overcrowding and the like, you will start to lose your gingival envelope, and that is the problem. And often in orthodontics, there's a danger of pushing the teeth through the buccal plate. The buccal or facial plate is very thin. And I know it's an old-fashioned term, but this muscle or envelope, is key. Keeping the teeth within that envelope is key, I think, to successful treatment. Next slide, please. Malocclusions, there's been studies shown that obviously certain types of malocclusions, deep overbite, and so on, you can get tissue damage through the teeth, which may in turn result in damage to the gingival margin. Next slide, please. Next slide. question of frenal attachment, often in the literature you see that is that important in the development of gingival recession? The question, I think, really is that one, there's no evidence that it is has an important role, but I think the reality is that it may make it difficult for people to clean if you have a very high attachment in the area. But when you talk about the so-called direct pull of the frenum to the margin, it's there's very little evidence in the literature. Next slide, please. Next slide, please. Again, we look at, as we've discussed from the previous cartoon, if you like, plaque calculus periodontal disease may impact on gingival recession. Also, treatment of gingival periodontal diseases can also have an impact on recession, and we have to be very careful in over-instrumenting pocket depths of less than 4 millimeters. Next slide, please. Toothbrush trauma, overzealous, we've discussed this. This evidence really is circumstantial rather than factorial, and it shouldn't really be considered proof of the actual cause. And there's no conclusive data to support or refute the association of toothbrushing and gingival recession. You also have to realize a lot of the earlier work was done on different bristle types, which may have been damaging, and some of the earlier abrasive may also be a problem. So we're talking in these precipitating factors. Next slide, please. Tooth movement, we've already discussed this. Again, I've mentioned about the thin buccal lingual plates. We have to be very careful. Any bony dehiscences or fenestrations, ideally it would be useful to identify there before orthodontic treatment is found. Put simply, the foundation of the bone, I think, is key for the coverage of the gingiva, and also in successful management if we're using surgical procedures to cover any recession. Next slide, please. Smoking has an impact on development of periodontal disease, and it affects the molecular and cellular level, and it may impact on the immune response, and also in wound healing. I've seen individuals who chew tobacco and similar non-tobacco products, and we do seem to get gingival recession, particularly in the mandibular areas. Next slide, please. Healing is obviously very key, and something what we have to be very careful of is that if you remember in the old days of the apically repositioned flaps, and some people still use apically repositioned flaps, particularly in crown lengthening procedures and the like, we may lose pocket depth, and it's pocket recession. But the outcome often then is that we lose a lot of gingival tissue, and people have more recession, both facially and luckily also interdentally. And as we've been discussing with the classifications, it's the interdental gloss which is key. So just be careful on how we manage the procedure. The clinical procedures now, the surgical procedures, I think are more and more advanced, very refined, but particularly with this minimally invasive periodontal techniques, we have very highly sophisticated techniques. We can use all sorts of perioscopes. Harold, who's been a proponent of this, but they're becoming very sophisticated, expensive, and almost limited in the hands of experts, and it's only when we start seeing these techniques coming out more and more into the general periodontal specialist situation, we see, you know, how effective these treatments are. So I think there's a good promise for future management of treatment using these specialist techniques and procedures. Next slide, please. Restorative dentistry has an impact. Our restorations, our crowns, bridges, and so on also have an effect. It has an impact on the cleaning. We may have, if we impinge on the biological width, as you know, most of you will know, you either get overgrowth or apical loss with the attachment going further apical down the tooth. So we have to be very careful. Next slide, please. Dentures also have an issue. You can see on the slide there on the abutment teeth. So we have to be very careful how the denture design is key. Next slide, please. And also we have self-inflicted trauma, chemical trauma. I've seen cocaine being used, put in the buccal sulcus, also studs and so on. Next slide, please. So the common outcomes, we discussed some of them. Dentine hypersensitivity, aesthetic concerns, probably patients are more concerned. Pain and aesthetic concerns, plaque retention, tooth abrasion, and caries, root caries. Next slide, please. Next slide. Yeah, this is simply a slide. It's a transient pain sensitivity. We generally just simply use a probe or cold air to assess the identify and assess the problem. Next slide, please. Aesthetics is key, as it's quite a marketing market now. It depends on the high smile line. Patients do not like black triangles, and sometimes this can be the result of treatment if we're not careful. And I think one of the issues which has been plaguing root coverage techniques for a while, and also in general periodontal circles, is how do you maintain the papilla. And then now there's techniques which have been utilized for that. But that's something key, and it could have a psychological damage to the patient as well. Next slide, please. So here, example, we see there's on this one dark root dentine and enamel, and you see here interdental loss. You see so-called black triangles. Now we can mask these, and in the short time we have left, we can quickly discuss it. You can mask this non-surgically as well with gingival veneers, but that creates its own problem. But that is a simple way of using it. But as you can see, patients may not like this. It's unsightly. Next slide, please. Plaque retention, gingival inflammation. Again, this creates problems cleaning and with also caries. Next slide, please. Next slide, please. Tooth abrasion we discussed. It's more likely to be abrasive than toothpaste. So you have attrition, abrasion. Some people call abfraction. They can be used. And also acid erosion. They can be used in isolation. Actually, there's a synergistic impact. So if you're having a very erosive, healthy diet, which you think is helping you, and you're brushing your teeth as well, taking orange juice. If you take the orange juice and then brush your teeth, there's likely, certainly in laboratory studies, there's likely that you can lose more tooth surface loss. Next slide, please. Again, root caries is an issue. Often you find as you get recession, there's also potential for root caries as well if the patient's oral hygiene isn't pristine. Next slide, please. So Van Dyke suggested indications for root coverage and gingival recession, and we've really covered most of these things, please. Next slide, please. I think it's important when you decide on what you're going to do, you know why you're doing it. Are you going to deepen the vestibule? Are you going to cover the root surface? Sometimes we do root procedures and we're not quite too sure what the aim of this is. Next of the procedure. Next slide, please. In this Zaire study, 2005, our group in London used the study, and also we used it in other parts of the Greece in particular, and I think in Kuwait. And these were clinicians who were given a questionnaire and they were asked what's the main problems, and aesthetics came up, stopping and the progression of recession. And I addressed this a little bit where I said that we need to measure tooth sensitivity, preservation of the pulp. So maybe the first three are key: aesthetics and stopping the recession and tooth sensitivity. Next slide, please. So there are two types of way of treatment broadly: non-surgical management of gingival recession and endophthalmic, and this is preventive care and non-surgical correction of defect. What I would suggest both for the non-surgical management and the surgical management, it is no use simply giving a patient a toothpaste and sending them away, or doing a sealant in the dental office or facility, or doing a root coverage procedure if you don't remove the etiological factors and the precipitating factors that cause the problem in the first place. And I think people often forget this. We can spend so much time on the root coverage procedures and the augmentation, and forget the basic thing. So my plea really, even if you don't get anything else from this lecture presentation, is that sort out the foundation before you do, where possible, before you do any recommendations. And that's difficult, I know, but we should at least attempt that. Next slide, please. So here, this is basically a guide for you can use non-surgical treatment, including preventive care, and this is recommendations: desensitizing toothpaste, and the various procedures that have been used from the literature. Again, identifying and correction of predisposing and precipitating factors is key. The use of photographs, clinical measurements, casts to chart the progression is key. And also there's the over-the-counter toothpaste and mouth rinses. There's a number there, and also obviously the treatment. With the surgical treatment, you've got the historically guided tissue regeneration, coronally advanced flap plus endogain, connective tissue graft, pre-gingival grafts, with the various things. There's more and more techniques and materials coming out, and there's an interest now, and I think there's looking at the program, others may be bringing in things like blood factors and so on, so that should be interesting. Next slide, please. Next slide. So again, we've addressed the black triangles. If we don't want to do any surgical of it, you can do simple things like adding or remodeling the crowns or the composite fillings to close the gap to make it less obvious. I've already mentioned that the use of flexible silicone gingival veneers the use of tooth-colored composites as a minimally invasive adhesive restoration may also be recommended. It depends on the size of the defect and the size of the problem. So the advantage of using something like glass ionomer, it's claimed that the fluoride release over a prolonged time. So aesthetic concerns can be raised by the presence of recession, and these can be resolved either by non-surgical or surgical correction. Sometimes simply smoothing off the defect may be sufficient as well. Next slide, please. And here the surgical one, and we've touched on this already, and for the sake of time, I won't prolong it, but certainly these are procedures that have been recorded in the literature, and there's success for most of them. Again, if you go back to the Caro and the Miller classification, you have to take into account your forecasts, and that is dependent on the classification that you're using. So you have to be realistic in your management. And I think that's true for both the patient and the clinician. We have to be realistic in our outcomes. Otherwise, we might get disappointed. Next slide, please. Again, this is something we've covered, and this is just a little bit more. I think from the course leading Prato, they would say that the optimal result of root coverage procedures would be the complete resolution of the defect, and that may occur. And one thing I would say is that looking at certainly the 10-year review figures with individuals who are very specialized, they recognize that there is there's a percentage of these defects that will once again start to show recession. Next slide, please. So it's been a little hurried. It's not ideal presenting this way, but I hope I've given you an overview of how to treat it. So our learning outcomes and takeaway messages: the management of gingival recession and associated clinical outcomes, including caries, aesthetics, and dental hypersensitivity or pain, can be addressed either on a non-surgical or surgical approach, depending on the extent and severity of the problem. It's important to have implement a preventive treatment approach that incorporates the identification and subsequent treatment or modification of both the etiological and predisposing factors. And this is essential irrespective of whether we do a non-surgical or surgical approach. And again, monitoring the condition over time to make sure that everything is correct and there's no further deterioration of the problem is an essential component of the management strategy. Next slide, please. Finally, I hope I'm still within time. I would like to acknowledge the contribution of colleagues, namely Wendy Turner, who was my co-author of the book chapter, The Management of Gingival Recession, on which part of this presentation is based, Petros, who was a postgraduate student, Marilena, who was a postgraduate student, Professor George Weathercaris, who kindly gave me some slides, Phil Auer and Robert Orton all contributed, and also Dominique Chatsakuna. And I would like to acknowledge their contribution as well over the years. Thank you very much. Thank you for listening.